Howdy, future nurses. What's up? So we're gonna break down DKA as simple as possible. So the way I'm gonna be doing it, I'm gonna give a 5 pre-test or pre-lecture question, and then we're gonna do the DKA breakdown, and then after that we're gonna have the question, additional 5 question at the end. So let's start, okay? So for question number 1, which is a pre-lecture question, complete this statement. In DKA, the body breaks down blank for energy. I'm going to give you 10 seconds to answer that. And then I'm going to provide the correct answer. Okay, so the correct answer here is going to be letter V. So letter B, so fats. So when insulin is low, the body cannot use glucose. So remember that, right? It shifts to fat breakdown for energy. So this fat breakdown produces ketones. That's why we see ketones in DKA. So this actually, the ketones production, which are the ketones acid, are the one that's driving the condition called DKA. Okay, so let's go to question number 2. So again, this is pre-lecture, and then I'm gonna talk about, break it down for you as simple as possible. So question number 2, select the best answer. So a hallmark sign of DKA is blank breathing. At the end of the 10 seconds, I'm gonna give you the correct answer. So also remember this as you listen to or watch the video. Okay, so the correct answer is definitely letter B, right? Kussmaul's breathing. So this is the type of breathing which is considered deep but very rapid. So you're gonna have respiratory alkalosis in your ABG. The body uses this pattern to blow off acid in metabolic acidosis, which is really the hallmark of DKA. As a matter of fact, Kussmaul's breathing is like a compensatory mechanism for patients who have DKA, especially if they're already having metabolic acidosis. Okay, so next question. Complete the statement again. DKA most often occurs in patients with blank diabetes. So our question number 3, that's our question number 3, okay? And so 10 seconds is almost up, so there you go. So the correct answer is letter A. So it's most often, right? Does it occur in type 2 diabetes? Yes, it does. But most often than not, type 1 diabetes is the one that's usually affected with DKA. It involves little to no insulin production at all. So remember, that's type 1 diabetes, right? Without insulin, glucose cannot enter the cell, making DKA more likely. So one of the salient features of DKA is that no matter how high, no matter how much you try, insulin is trying to open the door of the cell, it won't open it. So I call it the door, and we're going to talk about that. So question number 4, which lab pattern fits DKA? And so I'm going to provide the answer at the end of... Okay, so there you go. At the end of that 10 seconds, the correct answer for number 4 is letter B. So this is where there is high anion gap. So that's really one of the features, and low pH because of the acidosis. So remember, ketones are acids. When they rise, the anion gap widens, so usually around 16 to 18, but the normal value for an anion gap is around 8 to 12. So anything higher than 12, you kind of consider that as an elevated anion gap. And so when there is an elevated anion gap, the pH also drops. This pattern signals metabolic acidosis related to DKA. And our last pretest question, the primary trigger of DKA is lack of what? Let me put the timer there. Okay, so the correct answer here is letter A. Of course, lack of insulin, right? DKA begins when insulin is absent or severely low. Without insulin, glucose builds up, fats break down, and ketones is going up. Okay, so let's talk about DKA. So now that's our pre-test, and then at the end of this mini lecture, very very short lecture, you're gonna have another 5 questions. So let's start with DKA, right? So what triggers DKA? So DKA stands for diabetic ketoacidosis. So what triggers it is not enough insulin or no insulin at all. And so when there is not enough insulin, then the body is going to rely on fat for energy. And so when fats are broken down, they start building up ketones. Ketones are acid, by the way. So we call it ketone acid. So as the ketone acids builds up, then as I mentioned earlier, there is this wide anion gap, meaning to say there are more acid that were not measured normally when we do the chemistry 7, and then you end up with metabolic acidosis. Together with that metabolic acidosis, of course, is hyperglycemia, right? So we remember when you have high glucose contents, remember glucose pulls water together with it, right? So that's the reason why when people have diabetes, they tend to pee a lot. Polyuria is one of the signs of diabetes, and there you go with DKA. You have massive massive fluid loss, then you're gonna have dehydration, and that's the reason why one of the treatment or the first treatment is hydration. Okay, so let's go to the next slide. So what are the key manifestations? Kussmaul's breathing, which is rapid respiratory, at the same time very deep breathing, is actually a respiratory alkalosis. You're going to have this fruity breath because of the ketones. Every now and then they're going to have nausea and vomiting and abdominal pain, but because of dehydration, they feel so confused. They feel so weak because of that massive fluid loss. The next thing is what are the key lab values? Of course, you're going to see hyperglycemia. Like I said, the anion gap is really wide or really elevated. The normal anion gap is between 8 to 12. You're going to see with DKA around 16 to 18. You have a low pH because of the acidemia, and then of course low bicarb, and that's the reason why we have metabolic acidosis. And then the potassium tends to normalize a little bit and then tends to go up because hyperkalemia is usually associated with that low pH, which is metabolic acidosis as well, right? And then in terms of treatment sequence, and I put it in sequence because usually NCLEX like to ask this question. The first thing really is to rehydrate the patient, because all the medications that we're not going to give is not going to really go to the target cells if you don't have enough fluid to bring it there, right? So rehydration with isotonic fluids such as normal saline or normally normal saline, I was going to say LR, but isotonic solutions, right? And then together with that, you give insulin. And then at the same time, while you're giving insulin in this scenario, because you're trying to lower hyperglycemia, you kind of have to watch the potassium level, because that potassium level is going to go down. Then you're going to end up with hypokalemia. So the main thing is after giving insulin, you want to replace carefully the potassium level. Once the blood sugar normalizes around 200 or 250, depending on the hospital policy, they start adding dextrose in their fluid. So remember isotonic solution earlier, normal saline. Now you're going to add dextrose. And the reason why you want to add dextrose is you want to just don't drive that glucose down very, very quickly. And then during the process, you really monitor fluid balance and electrolytes. The other thing that really needs to be reassessed here is the anion gap. So you know you're getting better, or the patient is getting better, when the anion gap is narrowing, meaning to say it's going to the normal level, which is 8 to 12. Okay, so let's look at our post-lecture question. And so let's look at this. Complete the statement. The first treatment step in DKA is what? Look at that. So the correct answer here is going to be letter B. So remember, rehydration is the first step, right? DKA causes major fluid loss. Restoring volume comes first. Fluids improve perfusion, and it can also help lower the blood glucose level even before insulin starts. So that's the reason why we want to start with fluid. Question number 2. So let's select the best answer. Potassium may look normal or high at first because of what? So let me put the timer on. So it looks normal and sometimes it goes higher, and then after that you end up with hypoclemia because of the insulin. Okay, so the correct answer here, y'all, is letter B. So what's the reason why? Remember, acidosis drives that hydrogen into the cell, right? And then potassium ships out in exchange. So potassium usually stays inside the cell, but then because of acidosis, it's gonna really be zipped out extracellularly. This makes potassium look normal initially, and then sometimes it's a little elevated even when the stores are really low. Question number 3. So we complete the statement. Our rising an ion gap shows that. So in 5 seconds. Okay, so question number 3, the correct answer is letter B. So remember, ketones are acid, right? A rising an ion gap means that there is unmeasured acids slash or open and close parenthesis ketones are increasing. In DKA, this is reflected through the ketone formation. So let's go to question number 4. Which findings suggest improvement during treatment? Okay, so the correct answer for number 4 is letter C. These two changes shows that ketone production, especially letter C, is slowing down. You see the anion gap is closing, so it's narrowing. Fluids and insulin are working, and acidosis is getting better. Okay, so let's go to our last question. The nurse adds dextrose to IV fluids when. So again, this is very hospital specific. In your board exam, I'll show you which one to answer because they usually use that number. Okay, so the correct answer is letter A. So again, hospital specific, right? But in your board exam, they're going to use the word 250. Okay, so they're going to use the number 250. But the correct answer here is letter A, and the reason why, because I didn't put 250 in there. So insulin lowers glucose fast. When glucose reaches around 200 to 250, adding dextrose prevents hypoglycemia, while insulin tries to clear the ketones. Comment what content you want me to cover next time here on YouTube. So I'm new in YouTube, so thank you.